Assalamu alaikum. Our lecture today is about hemolytic uremic syndrome. In this lecture, we're going to know the definition of hemolytic uremic syndrome and its hallmark, the classification and its etiology, how can we reach a diagnosis of patient with hemolytic uremic syndrome, and how does a patient with hemolytic uremic syndrome present it to us, and lastly, how we can treat a patient with hemolytic uremic syndrome and what is the prognosis. Hemolytic uremic syndrome. It is a common cause of community-acquired acute kidney injury in young children. It is characterized by the triad of microangiopathic hemolytic anemia, thrombocytopenia, and renal insufficiency. The various etiology of hemolytic uremic syndrome and other related thrombotic microangiopathic allow classification into infection-induced, genetic, medication-induced, and hemolytic uremic syndrome associated with systemic diseases. The most common form of HUS is caused by toxin-producing E. coli that will cause prodromal of acute enteritis, and it's commonly termed diarrhea-associated hemolytic uremic syndrome. This is mostly seen in Asia and Southern Africa. Several serotypes of E. coli can produce the toxin. However, O157 and H7 is the most common in Europe and America. Other types is the genetic atypical HUS. This type is familial. It's usually inherited as autosomal recessive or autosomal dominant. Also, we have systemic disease like SLE following bone marrow transplantation, a patient with malignant hypertension. Lastly, HUS could be medication induced following some immunosuppressive therapy and cytotoxic medication. Understanding the pathogenesis of this disease is very important. It can simply lead us to the characteristic feature and the manifestation of the disease. In all forms of the hemolytic uremic syndrome, the underlying pathology will be microvascular injury within the endothelial cell damage. Usually, the capillary and the arteriolar endothelial injury in the kidney, especially in the glomeruli, will result in a localized thrombosis that causes direct decrease in the glomerular filtration rate. That will explain the occurrence of acute renal injury. With a progressive platelet aggregation in areas of microvascular injury, this will result in a consumptive thrombocytopenia. And microangiopathic hemolytic anemia, which result from mechanical damage to the RBC, as they will pass through damage and thrombotic microvasculature. In the diarrhea-associated form of hemolytic uremic syndrome, enteropathogenic organism producing either Shiga toxin or highly homologous Shiga-like verotoxin, both of which can directly cause endothelial cell damage. The toxin can directly activate platelet, so it will result in their aggregation. Regarding clinical manifestation of a patient with hemolytic uremic syndrome, the typical patient is usually a young child in a preschool and school-age child. However, it can evenly occur in adolescent and adult. In hemolytic uremic syndrome that is caused by toxigenic E. coli, the onset of the disease usually occurs few days after the onset of gastroenteritis. The patient will be presented with feature of gastroenteritis, which is fever, vomiting, abdominal pain, and diarrhea. The prodromal intestinal symptom, it could be severe and require hospitalization. However, it can be mild and considered to be trivial. The diarrhea in those patients is often bloody, but not necessarily so. After this prodromal illness, there will be sudden onset of pallor. The patient will have irritability, weakness, lethargy. which these symptoms usually herald the onset of hemolytic uremic syndrome. Patient also will develop oliguria. Oliguria can be present in the early stage. However, it may be masked by the ongoing diarrhea. Because the prodromal enteritis often overlap with the onset of hemolytic uremic syndrome, particularly with the ingestion of high dose of the toxin. Patient with hemolytic uremic syndrome can present either with significant dehydration or, on the other hand, the patient may have feature of volume overload. This will depend on whether the enteritis or the renal injury will predominate the clinical manifestation. Patient with hemolytic uremic syndrome can develop petechiae. However, significant or severe bleeding is rarely seen in those patients despite a very low platelet count. Patients with pneumococcus associated disease, they usually ill with pneumonia and pyemia when they develop hemolytic uremic syndrome. The E. coli is usually transmitted by either undercooked meat, contaminated apple juice, or bathing in contaminated swimming pool. Diagnosis is made by combination of microangiopathic hemolytic anemia with schistocyte, thrombocytopenia, and some degree of kidney involvement. The anemia can be mild at presentation, however, it rapidly progresses. Usually, the hemoglobin will be in the range of 5 to 9 grams per deciliter. Thrombocytopenia is invariably finding in acute phase. Usually, the platelet count between 20,000 to 100,000 per cubic millimeter. The Coombs test in those patients will be negative. However, pneumococci-induced hemolytic uremic syndrome, the Coombs test could be positive. Leukocytosis is often present and it's usually significant. When we do a general urine examination, we can see microscopic hematuria, low-grade proteinuria. The renal insufficiency can vary from mild elevation in the serum blood urea nitrogen and creatinine to acute anuric kidney failure. In a blood film of a patient with hemolytic uremic syndrome, you can see a cell which is called schistocyte. Schistocytes are fragmented RBC that can take on different shapes. They can be found as triangular, helmet-shaped, comma-shaped, with pointed edges. They are most often found to be microcytic with no area of central pallor. In patients with hemolytic uremic syndrome, other causes of acute kidney injury associated with microangiopathic hemolytic anemia and thrombocytopenia should be considered and excluded. Those conditions are thrombotic thrombocytopenic purpura, SLE, malignant hypertension, and bilateral renal vein thrombosis. Treatment. The most important thing in the treatment of hemolytic uremic syndrome is early recognition of the disease, monitoring of potential complication, and supportive care. Supportive care include careful management of the fluid and electrolyte, which include correction of volume deficit, control of hypertension, and early institution of dialysis if the patient becomes significantly oliguric or anuric, especially if the patient have hyperkalemia. Early intravenous volume expansion before the onset of oliguric may be nephroprotective in diarrhea-associated hemolytic uremic syndrome. RBC transfusion are usually required as hemolysis can be brisk and recurrent until the active phase of the disease have resolved. Although patients with hemolytic uremic syndrome have thrombocytopenia, platelets should not be administered regardless of the platelet count, because they are almost immediately consumed by the active coagulation, and theoretically it can worsen the clinical course of the disease. Despite low platelet count, serious bleeding is very rare in patients with hemolytic uremic syndrome. Antibiotic therapy to clear the enteric toxigenic organism, it can result in the increased toxin release, and it has potential for exacerbation of the disease, and therefore it is not recommended. Prognosis. With early recognition and intensive supportive care, the mortality rate for diarrhea-associated HUS is less than 5% in most major medical centers. Up to 50% of the patient may require dialysis support during the acute phase of the disease. However, most will recover renal function completely. Of the surviving patient, 5% will remain dependent on dialysis, and up to 30% are left with some degree of chronic renal failure. The prognosis for HUS that is not associated with diarrhea is more severe. Pneumococci associated HUS cause increased patient morbidity and mortality has been reported to be 20%.